back from lunch. And for those who are joining us for the first time, welcome to our Healthcare in Humboldt event. We have an amazing panel bringing a lot of richness in perspectives, and I'm really excited to be having this conversation. Just to summarize very quickly what we went over in panel one, we covered the impacts of limited healthcare access on the community, particularly when it comes to like the economy, business, workforce, stability or disruptions, depending on how you look at it. The limited healthcare being limiting factor for economic development and regional prosperity. And this panel, panel two, is going to be focusing, staying on the topic of impacts. It'll look at disparate impacts on the community, meaning the limited access to healthcare and the gaps in services that it may create are not felt equally amongst our population, right? And not felt equally, definitely geographically. So we, being a rural community in Humboldt, we experience the impacts in an augmented way. Similarly, different sectors or segments of our population feel the impacts, those impacts exacerbated. And so that's what this panel 2 discussion is going to be about. But before we do that, because we are having people join in for the first time, we're going to do introductions again. And I'll start it off. I'll kick it off. My name is Rosam Ruiz. I'm an administrative analyst for the Division of Organization Development and Effectiveness, housed under Human Resources for the County of Humboldt. And I'm going to pass it on to my colleague.
Thank you, Rosam. My name is Katherine Lourenzo. I am a program manager over the HRIS Data Management and Benefits Compliance Division for Human Resources, also for the County of Humboldt.
Thank you. My name is Jeremy Michael Clark. I oversee the Division of Organizational Development and Effectiveness, also in Human Resources at the County of Humboldt.
Awesome. Thank you both. And now we finally get to our panelists. I'm going to ask if you can share your name, your organization, what the role that you play in that organization is, and also to frame your participation. Can you talk a little bit about the work that you do and how that, what lens you're bringing to the conversation today? And feel free to spend as long as you need to do that.
Starter serves individuals with mental health and co-occurring IDD diagnosis. So we serve individuals who are regional center clients who have complex mental health needs that are not being met within the system and the support that's available through the regional center. So we currently serve about 43 individuals within Del Norte and Humboldt County. And our job really is to collaborate with all of the other providers within the county that support our clients to make sure that we're building capacity within the community and helping our individuals thrive as much as possible.
Hi, I'm Dawn Arledge. I'm the Executive Director for the California Center for Rural Policy, CCRP. We're at Cal Poly Humboldt, and we have a lot of different projects that focus on community health and well-being. Of note, we're convening tribal lands, Humboldt, Del Norte, Mendocino, and Lake counties on Redwood Region Rise, which is a regional project that really looks closely at the intersection of health, the economy, the environment, sort of the entire ecosystem childcare, broadband, housing, and how all of these things together impact the health and well-being of our region. We've also done a bunch of work. In fact, Sarah and I worked together on some oral health work in the county and access to oral health care. I have a lot of great staff and partners that make it possible for me to speak to these issues and to do the work we do at CCRP. So I'm excited to bring forward some of those thoughts and ideas from residents, from our staff, from our amazing community partners, to hopefully contribute something meaningful to our conversation today. It's a really important issue. And I'm really honored to be here with my other panelists. Sarah.
Thanks, Dawn. Hi, good afternoon. My name is Sarah Ross, and I'm the Chief Operating Officer at Open Door Community Health Centers. Open Door Community Health Centers, we're in our 54th year. We grew from an organization that was a small free clinic next to, that's now Tin Can Mailman, to having 13 health center locations across 2 counties, Del Norte and Humboldt County. And now being the largest provider of primary medical, dental, and behavioral health care in our region. And I oversee our health center operations primarily, and I'm excited to talk about the work that we're doing and the way that we're really trying to ensure support of the health and well-being of our community.
Good afternoon. My name is Nina Tillman, and I am an integrative manager at Lima's Pharmacy, a compounding pharmacy that has been in Humboldt County for over 25 years. I work alongside my pharmacist doing hormone consulting for men and women, as well as different style testing, specialized medication for humans and for animals. So we love your babies too. I also, in addition to my role in Lima's Pharmacy, I also have many roles, actually. I work with a rural health center conducting prior authorizations. I am a liaison for them to help and support patients getting their medications covered that are complex and non-formulary, as well as I am a student. I'm in a distance education program, so this pertains to this panel's conversation, as I am one of your health professionals that is seeking education elsewhere because we do not provide the program that I'm in. We do not provide that in this county. I am excited to be here, and I appreciate all of you being here as well.
Thank you so much for those introductions. The topic at hand is a little heavy emotionally, but also data heavy. And while the contributions of our amazing panel will be rooted in data, we've asked them to also humanize the data by providing anecdotes or storytelling wherever it is appropriate. Because we do want to center the human experience, we want to ask a question of you that will help us pivot into the or transition into the question to our panelists. So take a minute to take out your phone, and you can go to use that QR code to answer that question. Or if you're having difficulty centering that QR code, you could also go to slido.com and enter that 6-digit, is it 6? 7-digit number. I'll pause for like a minute so that you can get in. Or apparently my mouth wants to do something else. It wants to just keep talking. But and just keep in mind that the your responses will be auto-populating. But also you can vote. You can click as many of these that apply to you, and we'll see why in a second. It'll make more sense, hopefully, after we see a few of these. Oh, perfect. And by perfect, I mean it's working. Not that perfect. Look at you. Horrible experiences across the board. That's not at all what I meant. This goes to the comment that I had made in the beginning, and it'll make obviously more sense once our experts chime in. But I had mentioned that the experiences of people are not the same across, and this is something that I suppose most of us intuitively know, but the data then suggests in which ways our experiences are different, depending on where we are geographically, depending on where we are situated socioeconomically, our ethnicity, our age group, our gender, sexual orientation, and so on and so forth. Um, and for some of us, actually, these categories or ways that we can be, that our population can get segmented, intersect, and sometimes with horrible consequences. And I'm jumping ahead of myself, but you can continue to vote. We're gonna reference this most likely further down the presentation, but I'm gonna move on to the next slide. You can continue to participate. Thank you. The pie chart on I always have difficulty with this. On the right hand side comes from the California Healthcare Foundation. So at the state level, we also see similar responses as the ones that came from you. In particular for Black people, right? The perception is that for 1/3 of them is that they've been treated poorly due to their race. But when you add the layer of segmentation to which I was alluding earlier, that is when you have Black people who are also part of the queer community, or Black people who have a disability or perceived disability, the numbers of self-reporting, perceiving poor treatment increases significantly. And because we are talking about impacts, one question that I would have is, what does this mean for this particular group of people? And alarmingly, it means that over 41%, and this is at the state level, over 41% of Black Californians who are also LGBTQIA plus members avoid or have avoided healthcare in the past because of fear of discrimination. And this is where I would like the participation of our panelists to really illustrate and materialize this into like storytelling, because when we look at numbers, they're striking enough, but what does those numbers mean, right, for the people who are our neighbors, relatives, friends, right, in Humboldt County. And on the left, you see that locally, Providence, through their community health needs assessment back in 2019, identified this as being one of the issues, both racism, right, and historical mistreatment of Black, Brown, Indigenous, and people of color, right? That being a limitation on this group of individuals to getting high quality, respectful, responsive healthcare treatment.
Thank you, Rosam. So, as Rosam stated, these healthcare, these experiences are obviously very impactful and harming to our community. And something that I wanted to speak to just briefly as we prepare to open up to our panel for questions is that we have some data on healthcare outcomes within some of the groups that we surveyed our attendees today. And you can see here, and I'm going to use this pointer since I feel like that might be easier to point out. But actually, real briefly, let me just step back. So we've got two charts here. One is looking at our Redwood Coast, rural Redwood Coast, and one looking at the state of California. To start with, I'd like to just focus on our rural Redwood Coast, and as the conversation progresses, we'll look at some comparisons. But I want to just focus in on how the experience is different and the disparate outcomes and experiences within some of the categories that we're discussing today show up for people in these groups. You can see here at the bottom of the slide that this darker blue color represents lower risk, and it transitions up to this darker sort of yellow, burnt yellow color as higher risk. And in the category of fair or poor health status, we see folks who are disabled versus not disabled. There's a huge disparate outcome here, 41% to 9%. As people age, we see some pretty large significant differences here. People of color versus people who are white or white representing, 21 to 16%. And there are multiple different categories here, and obviously some of them are going to have more significant documented differences. But I think what's apparent here is just that, one, that these differences need to be discussed and brought to light, and obviously that there are more categories than are what are represented in this chart specifically. But I wanted to share this for something to reflect on, and as we prepare to open up to our panel, I'm going to look to our panelists and ask, how do these inequities show up in your work, both based on the data that you've seen and also what Rosam has introduced with today? So I'll look to you all you can choose who to start the conversation, but again, how do these inequities show up in your work or the data that you've seen?
Okay, I was going to start just because our center did this chart, and it is a busy chart. There's a lot of information and a lot to unpack. And so maybe I'll talk a little bit about big picture of this, and then I'll hear from the other panelists. And it's really cool to see, Katherine, other people look at the data and interpret it, because I agree with the things you noticed, and I noticed them too. And I was talking to Wendy, she noticed some similar things. Basically, though, I'd say, the darker shaded boxes are where you see more disparities or inequities. And you pointed out some of those. The little stars that you see are, that means it's statistically significant difference, which means that it did not occur by chance. The flat line that you see, like if you look at violence by intimate partner for homosexual, bisexual, heterosexual, that line means the numbers are unstable. So it just means that there aren't enough numbers there to be absolutely certain that this is a significant inequity. It doesn't mean it isn't. It just means that there isn't enough data. And so some of this really, it does speak to in rural, one more thing first. Redwood Coast, we're talking about tribal lands, Humboldt, Del Norte, Mendocino, and Lake counties. We've done this kind of analysis for all 12 counties in California's rural north. And one of the first things that I want to say is that this is not a Humboldt issue. It's a rural issue. And our rural peers are experiencing really similar things to what we're experiencing in Humboldt. I'm not saying all rural counties are the same. They're not. But it is being experienced more broadly. I can only speak to California, but this is it really is a rural, partially a rural issue. The other thing with some of these groups is that if you were to just look at like Del Norte County, the numbers would be so small, everything would be unstable. So the benefit in looking regionally is it generates more data and more information that can point us in directions. This all comes from the California Health Information Survey. It is self-reported. So when you look at it, you can think about things that people, when they self-report, they tend to report the way they think they should. So an example of that is you might report you exercise more than you actually do exercise. You might report that you drink less than you actually drink because you think, what am I supposed to say to this? So when you look at some of these numbers, can imagine that could actually be higher because it's self-reported. And that this data is not perfect. It is self-reported data, but it's some of the best information that we have. And then one last thing is just a couple of the acronyms on here for those of you that are really interested in the chart. Below FPL is below the federal poverty level. Less than BA is less than a bachelor's degree. So that's your educational attainment. Metric ACEs are adverse childhood experiences. And I think those are the main acronyms I saw that I wanted to make sure people knew. And yeah, I'd like to pass it on and hear from some of our practitioners that are doing more than just working with data to hear their perspective on this.
Yeah, this is a very interesting chart, and I really appreciate hearing your analysis of it, Dawn. One of the things about Open Door is we're sort of unusual for federally qualified health centers who are these designated health entities designated by the federal government, and it allows us to receive some benefits like enhanced Medicaid rates, or in California, Medi-Cal, some grant funding from the federal government, and also a lot of responsibility and regulation and expectation that we are here to provide care regardless of insurance type, ability to pay. And then lots of regulations and expectations around the quality care that we provide that we're measured on every year. What's somewhat unusual for federally qualified health centers, which came out of the civil rights movement many, many years ago in the South, and then sort of spread. Health centers kind of grew out of whatever their community sort of social justice movements were. And so in Humboldt County, it was really the sort of social justice movement of, the hippies who recognized that there were a lot of people who were not able to get health care because they didn't have health insurance. And that is very, very inhumane and unfair, and so started offering free services, and then eventually became a federally qualified health center. One of the very first doctors, Dr. Bell, who was one of the founders of Open Door, still works with Open Door, taking care of our community, which is pretty amazing. And what that means in Humboldt County is that, and Del Norte County, is that unlike many federally qualified health centers who predominantly provide care for uninsured and Medicaid patients, Open Door really provides care for everyone in our community. So our payer base is 21% Medicare, 4% currently uninsured, which we're really proud of that low rate, and we work really hard with our patients to make sure they have access and understanding to what benefits they're eligible for. We have a whole team, our member services team. That's what they do. They connect with community members and they connect with patients and make sure that they're enrolled. We have 45% Medicaid or Medi-Cal, and then we have 30% private insurance. So, I go to Open Door and my family goes to Open Door. And what that means is that we have a variety of, like the folks on this chart are our patients in all the ways. And so we see, these disparities also showing up for our patients in the ways that we want to care for them and uniquely reach them. We've talked a lot about adverse childhood experiences in particular, and we've been fortunate to have some funding opportunities through this state over the last several years to really develop mechanisms for screening for adverse childhood experiences so that we can then connect with both internal resources as well as community resources like First Five to really try to wrap our arms around and support patients who have had three or more adverse childhood experiences. Another thing that we've talked a lot about is our workforce, sort of dovetailing off of this morning's presentation around workforce. We recognize that our workforce is our community, which means our workforce also experiences many of these same challenges that they're overcoming. And what are ways that we can have a trauma-informed lens to support our workforce of over 800 staff so that our workforce can then care for our community. So those are some of the things that I was reflecting on as looking at this data and sort of hearing Dawn give the detailed review.
Sarah, sorry for interjecting. Would you mind explaining what ACEs mean, like adverse childhood experiences, please?
There's sort of 10 identified adverse childhood experiences that are experiences that one can have generally in childhood. And they include things like physical abuse, neglect, having a divorced parents, having a parent who's been incarcerated. But they're these experiences that are deeply traumatic for a person who experiences them. And they're not, they sort of use the 3 or more because there have been many studies that have demonstrated that 3 or more is when you notice the consequences and the consequences of toxic stress, which can result in behavioral health challenges and can also result in clinical challenges like increased chance of heart conditions, increased cancer diagnoses, because when you root cause it back down, someone went through 3 or more of these experiences as a child, and it has that intensified result.
Thank you for doing that.
Hi. So I took a moment when I was thinking about what this question meant and what I see every day. And, part of what we do in pharmacy when we were retail prior to us flipping over to being just a compounding pharmacy is we serviced your community members all over. We did, long-term care. We helped with patients who needed blister packing, who had care providers. We worked with companies like Open Door. We worked with all of your local providers in servicing and providing your community with medications. And one thing that we realized in doing that during the last part of our retail life in Lima's pharmacy was that we were not being taken care of. Our business was not being serviced by the insurance companies that we were having patients utilize. We were getting taken out. So one of the inequities that I can tell you about is that the entities themselves are experiencing that due to our infrastructure in healthcare right now and the insurance companies and the way they have structured their paying. It has created a disparity to the point where we had to make a decision that was best for us as a business and for the community, because we still wanted to service the community and stay in business. So we changed our business model to compounding only, which is what we had been doing for 25 years. So it wasn't something unknown to the community. Although it changed the dynamic because we had to make a decision as to if we were going to accept insurance or not. And what I will tell you is after much deliberation and crunching numbers, it just was not feasible. What we found, though, is that it was actually better for patients that most of the services we provide at Lima's Pharmacy is not accessible through insurance regardless. So that brings me to the next inequity. Women. We are not cared for in the healthcare system. We are understudied, we are undervalued, we are undernourished, and we are not listened to often. And so I work with women daily that come in and sit down, and they break down because they've asked their provider to consult them with their hormones, to go over the whys and hows of their hot flashes, their weight gain, the lack of sleep, the lack of libido, the lack of I maybe just want to float around like a blob because I don't really have interest in anything. Those are all deduced to, well, you probably have anxiety. You probably have depression. Are you exercising enough? And oftentimes we are so dismissed. And what I will tell you is over 80% of the autoimmune diseases are female now in this country. So there is a rampant amount of autoimmune conditions that are coming out. We are now seeing that women were not speaking about their different symptoms. They were instead just dismissing them. And now we're finding that they are complex and that they have autoimmune conditions. Leads into what Sarah was speaking about, those child experiences. We now know that that is linked to a lot of the adverse problems that happened in your childhood. So PTSD and complex trauma can lead to these diagnoses. Often are dismissed by providers because the symptoms kind of mimic you just being a female in some respect. If you have itchy skin, if you have pain, oftentimes you'll hear a woman say, I have pain, but I thought that was normal. I'm one of them. I'm one of the autoimmune patients that did that. And often what I also see is women being told by providers that they legally cannot take their hormone panels, that they cannot, or that what's the point of testing your hormones? Well, to that, I would say, what's the point of testing any labs? Those are all snapshots of you on a Tuesday. It's about putting everything together and advocating. Women have a higher rate of cardiovascular disease after menopause. They have a higher rate of osteoporosis. They have a higher rate of anxiety. We are the highest in sleeping aids. We are the highest in depressants. We are the highest in medication for bone modifying. And that is to speak to the fact that we are not being advocated for in the healthcare system itself to provide the services that are necessary to having women live longer, age better, and to be happier. Quality of life is important to women and to men. I do not see on here women and men, but I understand that there was some, and I also wanted to say I agree with you. We do intake forms, and often I tell patients, this is not a report card. I don't want you to tell me what you felt the best at. I want you to tell me where the worst parts were for you. And so self-reporting can be really difficult. But what I do notice is, on there, you're looking at, suicidal ideation, falling below the poverty level, current smoker. Oftentimes you notice that women are high in this, but we will not say it. So remember that as a woman, you need to speak and advocate for yourself in your healthcare system. One of the things that I do in my job is advocate. I am there to be the advocate. I set the patient up with studies so that they can send them to their provider, so that there is some continuity of care where they have some resources to give to the provider to say, no, I actually do want to understand what's happening to me. And this study kind of helps explain it. Also being there as an opportunity to listen, to just listen. They spend 45 minutes to an hour with me just telling their story. It's important that we start to create this dichotomy of women are important in our healthcare system, and that if you are experiencing unfortunate symptoms and your provider's not listening, to please reach out to people like Lima's Pharmacy, to open door settings, to other healthcare professionals that are willing to listen, because often those issues can be mitigated, simple and supportive and not dangerous. The other thing that I would say in equity is students. I'm a student, and I was a pharmacy technician prior to this, and I was everything on that list. I came from a very poverty-ridden life. I was a mother at 15, a wife at 16. I did not go to high school. I finished, as my freshman year, I dropped out, and I ended up saying, well, these mid-level positions are probably what's there for me as a community member. because I didn't feel that I was worthy to go to college. And then something shifted within me. Part of that was the owners that are very, close to my heart helped kind of push me towards the initiative to go to college. But there is no pharmacy school here. There is not a lot of options for healthcare professionals other than the RN Bridge program. So part of that inequity in our community is looking at how do we bring healthcare physicians to this area? Well, why not change that dichotomy to how do we get people to want to become healthcare professionals in this community? How do we get them to want to stay here? I love this community. I bought a house here. I have 3 kids, soon to be a grandma, and I will stay here for the rest of my life. And part of that was I had to find a school that was willing to support me. And I had to utilize a distance education, which is not easy by any means. Doctoral programs are very rigorous and you have to be very engaged. Had I had a program that was local to my area where I could have been inside a facility in a lecture hall learning, that is something that would be a very important thing. I see a lot of students here that we've had interns come in who are local patients, local people, community members that end up going to, University of Washington, UOP, places that are outside of this area, and then they usually don't return back to this area. It's very rare for them to return because they get opportunities outside of this area because that's where they went to school. And a lot of those schools will fast track you to their institutions that they're connected with. So one thing I would bring to the county conversation and to the healthcare professionals and places like Open Door is how do you bring more education to this area? We need education. We need people like that 15-year-old girl who's a mother to know that it is okay to go forward in her career in life at some point and to venture out, that these stats do not define you, and that we have an opportunity as women and as community members to really drive this healthcare system into a place that is more supportive for the whole body, including our hippie population. Thank you.
Okay, so piggybacking on that, START does a lot of training. So I'm glad that we're here. I feel really motivated and excited to do more training with our community partners because I do think training is so much of the answer of what we really need. So kind of backtracking to START and what we do and who we serve. Right now, START serves a very small amount of people in this county, and it is because they are individuals who have fallen through the cracks and meet so many different of these categories. So we serve individuals with disabilities. So we're looking at the largest number of people who are not getting what they need in their healthcare. And then you look at the compounding additions to that, and the individuals at START are very complex. So we hold small caseloads so that we can really take a deep dive into what each individual person needs on a bio, psycho, and social level. And it crosses so many of these. So many of our clients are dealing with gender identity and sexuality and their disability and their mental health, and so many compounding factors that make the group of people that we serve those that really absolutely don't get their needs met in healthcare, and what do we need to do to help advocate for them. So one of the things that START does is we're serving that small group of people on a very complex, in-depth level, making sure that when they go to the doctor, that there's someone with them that can advocate to make sure that what they're saying to the doctor is exactly what should be said to the doctor, that they're hearing the right information, so they're not getting what's happening for the majority of them is a whole litany of diagnosis and medications and polypharm that's being thrown at them, because every time they go to the doctor, they say what it is they're currently feeling in the moment. It may not be a direct representation of what's going on. So we're really targeting these individuals to help make their access to healthcare better. But in the big picture, what we see happening is like we're looking at a small group, but the problem isn't staying with that small group. We identify within the community what is really needed. So, for example, for START, I do some training with our CIT team. So the CSET officers in Eureka, we're doing training to train law enforcement. We're also working with the emergency room department to supply social stories and laminates and augmentative communication so that they can tell patients what's going on and communicate with them. And the reach is to reach everybody. It's looking at these disparities and going, we realize that our developmentally disabled and our mental health population are not getting what they need, but what can we do not just to serve our small group, but to reach through the greater community. So I love that START is here. We've only been here in this county for 2.5 years, so relatively new team. So a lot of work still needs to be done on networking and outreaching and making sure that our partners are all connected. But really the goal is to make sure that we are targeting that training, that we are working to build capacity within the community, because the more we increase our capacity to serve, the more we partner together, the more the population, not just our developmentally disabled population, but the more the entire county, everybody that we serve is understood and gets better care. So one of my biggest drives at START is to do community training and to reach out and go, what are these problems, right? Where are we seeing the disparities? And make sure that we're bringing that training to our providers and working together to hear what those needs are. And all of these community players up here are all people that START, will be, if not partnering with, to make sure that we're all on the same page.
Thank you all for that. Just as an extension of this, I'm curious about what you've shared is really powerful, and it really gets me thinking about, do we have proper representation to meet the needs where we see these disparities occur? I mean, we may not be able to accomplish that in every category, but what work do we need to do in order to establish proper representation, and how does that impact care?
I think that part of, because my realm is not quite represented up there, but it's understood, is helping to educate. Providers need education on hormone replacement therapy, on the pros and the cons. They need education on women's health. They need to be doing regular, continuing education on women's health. Primary care is very difficult. You're kind of a jack of all trades. You have to know everything about everything and nothing about nothing. And that's a problem when you're looking at a dynamic human like a woman who is maybe going through something that is specific. And there's a lot of this, like autoimmune conditions, for example, we get put out to different agencies in Santa Rosa, and often those are waiting lists. So educating providers, letting them understand, maybe holding more trainings on these very specific diagnoses that you can educate on specifically in women's. My daughter, she is a patient who is complex. She has POTS. I would tell you that probably 90% of the providers do not even know what that is. It is a very scary autoimmune condition, autonomic condition that is affecting the cardiovascular health of a patient who is between the ages of 16 to 26. These young ladies are having heart rates above 180 beats per minute. Their blood pressures are very high and they're complex. And what they will tell you is, I have anxiety. This is that generation of I have anxiety, but we're not listening to them because it's not anxiety. It is a complex issue that we need to be educated on as providers. So education is one piece, I feel, and then bedside manner, professionalism. We need to hold the bar. I'm in a program that is on Zoom, and in my lecture hall on Zoom, I am to dress professionally, regardless of how I feel that day. And I know that kind of probably seems a little odd, but I often see providers, I often see healthcare systems where the professionalism is lacking in this county because we are very relaxed, rural, and comfortable in our space. We need to create more of a professional atmosphere for patients. They need to walk in and feel like they're heard, they're listened to, and that you are not a burden to their time. And often I hear patients say, I just don't think my doctor cares. I don't think my doctor wants me to tell them these things. They don't have time. What are we doing is my question. I took my very large debt to go to college because I wanted to help patients, because it truly mattered to me that the people around me are getting exactly what they need. And I feel that we're not raising the bar in this county for healthcare systems. We're just assuming the position and assuming that the patients all have the same issues. They do not. They are complex. they are humans that need to be listened to. So I really think the biggest piece of this is continuing education and holding more trainings for more complex issues that maybe aren't just hypertension and diabetes related.
Thank you, Nina. And as we go down the line with our panelists to you add your contributions, I would like to for you all to also consider the numbers that we had seen displayed earlier, the results from Providence Community Health Needs Assessment, where they identified racism and historical trauma as informing the lack of trust or mistrust that some segments of our population feel vis-a-vis healthcare providers or hospitals or clinics. So as you answer about representation, please also take into consideration the how that impacts trust or lack thereof of the populations that are most at need. Thank you.
Okay. At Open Door Community Health Centers for the last 10 plus years, we've had a interdisciplinary group called the Racial Equity Alliance. We also have a trans task force, and it's an interdisciplinary group of providers, care team staff, administrators who come together and really continuously educate ourselves and then talk about what are the education and policy and process changes that we need to continuously be analyzing and making to ensure that we are paying attention and that we are putting our work and energy and systems behind the, generalities of inequity. And like a concrete example is when we rolled out a new consolidated situation reporting system, which was the first time we moved from analog paper to a digital system for filing all complaints. We realized that we didn't have a differentiation broken out for racial, gender, discrimination, harassment. And so, worked through the system, partnered with our compliance team to break that out as its own distinguishing category. We have lab and diagnostic, we have HR, we have violence, but really calling out and naming racial and gender harassment and being treated unfairly due to that, which gave us the internal data that we needed, one, to be able to respond, because we found that people might not be reporting things because it wasn't violence, but it was harassment or bias based on gender or race. And so we wanted to make sure people knew that that was something we wanted to hear from them. And this is patients and staff. And then it also gives us the opportunity to sort of look at the trended data over time to see where we might have themes and where we could make systems level changes. And one of the changes we made is actually adjusting our patient rights and responsibilities, which is, displayed in all of our waiting rooms, and it's part of our patient packets to, again, call out and name discrimination, harassment based on gender or race or ethnicity, naming that as one of the expectations and responsibilities for both patients and staff alike. Because that was another thing that we found, is that staff didn't necessarily know how to respond if they had, racism coming at them, that they weren't sure if, the customer's always right, or I need to be nice to the patient, and being clear in our protocols and processes with our staff that is an opportunity, like that is not okay. We don't have tolerance for that. And we have a process for disruptive behavior and violence. And this is a form of that. And we want our staff to be empowered, and we want our patients to feel empowered to be able to respond in the same way that they would if there was another type of disruptive or violence. So it's those types of changes that we want to really call out so that we have, like, by naming it, we have clarity and we have processes. So that's one of the things that we've really worked on over the last 5 to 10 years to build into our systems. And it, we see it on the human level, the actual care level. We see these things show up, like I said, and training. I wrote you down, Wendy. I was like, we need Wendy to come, and because one of the things that Open Door, yes, we are rural, and we're actually quite large. I think someone in the last panel said small urban, which I kind of liked, because it does feel like, especially Eureka Bay area is kind of more of a small urban. We have a lot of resources. I grew up in Garberville and Eddersburg, so this was the big city. And one of the things that Open Door has really stood and put energy behind is that training and the ongoing training and pipeline support. So that includes, for our current providers, we have 125 providers: medical, dental, behavioral health, pregnancy, GYN. And we have monthly clinical lunch and learn series where we either have local organizations or local providers share specific content information and updated education at CME for our providers, or we beam in people from UCSF or other parts of the country with their clinical expertise, because we want that continuing education to be something that we make available to our providers, and that it's part of, like, baked into our expectation that we are continuously learning and that we are doing clinically competent and updated care. The other thing, and I don't know when to squeeze it in, so I'm going to say it now in case it doesn't come up later, but we have residency programs. We have advanced practice clinician residency programs, so that's physician's assistants and nurse practitioners. We have a family medicine residency program, which are family physicians, and that's a partnership with St. Joe's. We have dental residents, and one of the things that our community can do to support the next generation of providers is to partner with us as patients and be willing to work with our learners as patients. So our learners all have precepting providers behind them, but we have become, as we have continued to try to grow the next generation of providers who will come, who will study here, and who will stay in our community, it means that more and more visits are going to have a learner in that visit, a physician resident or an advanced practice clinician. And one of the things that is a challenging dance is, and we would never want a patient if they're very uncomfortable or if they have a very bad experience, certainly. And I want to, like, get the word out and try to sort of, like, educate my friends and neighbors in the community of, like, join us in helping train the next generation by saying yes to having a learner in your visit with you and in your appointment, because we really, they need to learn, and they need to learn here, and they need to meet us and learn us, and we want them to become really excellent physicians and clinicians in our community and stay in our community.
Great. That was great. I wanted to talk, I have a couple points to add. One was about the previous slide and this slide. And Rosam, I think you mentioned fear and how being discriminated against or treated differently, like all the things that can create fear of seeking healthcare. So Sarah and I and other partners, we did a bunch of focus groups and research when we were looking at access to oral health. And we talked with people, parents who were on Medi-Cal Dental, and just talked to them about seeking dental care. And I was really surprised and will never forget how much fear of the dentist came up. And that's sort of a thing we talk about. Like, people are afraid of the dentist. It's like a thing everybody says, but what we don't do is think deeply about what is the impact of that fear. And it is what you said. It is that people do not seek care. They delay care. They don't get preventative care, and they might wait to see a dentist until the pain is so bad that they go to the emergency room for dental pain, which is not a place that is going to be able to address that pain. And so I will never forget that research and that study, because it just underscored how powerful fear can be in, I mean, all kinds of aspects of our lives, and what creates that fear can be all kinds of different things. But fear of a dentist or of the healthcare system or of asking for help if you're struggling with mental health issues, these are fears that are really important to address and overcome so you can get the care that you need. So it is a huge and hard to measure through data, that feeling. And I think what comes up with a lot of the disparities in inequities is, like, you know, a fear of sharing honestly what's going on with you, a fear that you might be judged, a fear that you might be treated differently. And it might actually mean that you don't seek care. For the oral health work, it meant for those parents, they were nervous about letting their child go to the dentist without them standing right there. And for it, and so they would delay care for their child, and then they would feel ashamed that they were delaying care. But it was all kind of, the fear was at the core of this. The other thing from that study that I thought was really interesting was how many non-English speakers that we talked to said that walking into that office and no one spoke their language, that what that the impact that had on them. So it turns out people said, you know, the office environment, the language is spoken, like how they're treated really, really matters. And then the other thing I wanted to say about the other question is that at CCRP, we work with lots of partners. We don't provide direct services. We don't provide healthcare. I do want to say these are complex problems, and there are a lot of organizations, people, agencies that are working to make it better. And no one organization can solve this, nor can it be solved for community. We solve with community. Like, we are all have a part, I think, to play in this. There's a lot of good work happening, a lot of partners that care a lot and are working on this. And it's natural silos are created mainly because of funding and payment structures that prevent us from seeing people like as a whole person and caring for them as a whole person and all the things that impact health. And so, you know, these silos that are created are not, we didn't create them, but we have to navigate them and overcome them together and with community. And it's a I guess I just want to say it's a really complex ecosystem. And even when you think about, you know, what are the things that contribute to health and well-being, there are so many things. It's your social support network. It's is your house in good shape? Do you have a place to live? Do you have access to education? There are many, many things that contribute to health other than what the doctor does or what the dentist does. And so it's all levels of this like ecosystem have a role to play in moving us toward improved community health and well-being. And I would love to hear what you have to say about this.
So I'm going to echo some of the things I've heard, which is training, and more training and collaboration. So definitely cross training, right? Across disciplines, understanding what one another is doing and gaining information from each other to make, collaborative understanding. I think a big thing that I haven't heard said much of yet, that really, it just rings very true to me all the time because we work with an IDD population at START. 90+% of individuals with IDD have experienced some level of trauma. In Humboldt County, we have one of the very highest ACEs scores in the nation. I think we're second in the nation. But when I look at like the START numbers of what we have on our data tracking, I see a very low representation of trauma, really low. Like I think our number for individuals with trauma, 25% of adults and 18% for children, does not at all mirror what our numbers say. And likewise, what I see on our schizophrenia spectrum is 22%, when we're really should be looking at a number that's closer to about 3. So we're not diagnosing trauma or acknowledging trauma near as much as we should be. And that to me says we don't see it, we're not understanding it. And that plays directly into individuals' access to healthcare also, and not wanting to go because they don't feel understood and feeling judged and blamed. And there's a lot of intergenerational trauma that has happened, not just in our county, but across, everywhere. But it definitely plays out here, especially with our Native American population, who very much feel like their child's behavior is being blamed and they may be taken away from them because we don't understand, right? So I know that it's echoing a lot of the same thing, but it really does take all of us to have both of our eyes open, our ears open, and be very curious and really looking into what it is on a complex presentation for an individual. We are not just our biology. We are not just our experience and our socialization. We are a makeup of our bio, our psycho, and our social. And when we look at helping people, we have to look at every aspect of that and how they interplay on a very complex mix. And the only way that we can do that well is to join each other in understanding, communicating, and helping support our individuals. So like at START, for example, we'll go with an individual to their doctor. We go with them to their mental health provider. We communicate with their supportive living staff. We'll talk to their employers. We write a cross-systems plan. So all of the individuals that we serve have cross-systems crisis intervention plans that we teach everybody who works with them about. We've started stretching that into larger groups like the emergency room and trying to make sure that the ER staff at St. Joe's understands the people that we're working with, and at Mad River that they understand, but not just understanding just our group, but how that carries into everybody and what tools we have that are available that we can share with one another to help make sure that we're representing and understanding them the best that we can.
So I worked in a telehealth company called Bright Heart Health, which was a company that did substance abuse and mental health for patients. And an interesting thing that I noticed was a lot of the dichotomy of patients that came in were patients that were houseless and didn't have access to care in actuality in our county. And one thing that I would love to see our health systems do is a better job of managing substance abuse and mental health. Currently right now we have induction programs through Open Door. We have induction programs through St. Joe's. As far as I'm aware, that induction program is the ER. That's not a sufficient way to care for our substance abuse and mental health patients. We need more boots on the ground. We need a better service for those patients. We also need to really look into the root causes of these concerns. Oftentimes I do neurotransmitter testing and I find that patients with anxiety actually do not have anxiety. They have histamine issues. And histamine is part of your neural activity that mediates an allergy. it is an excitatory part of your brain. It can cause heart palpitations, it can cause anxiety in the brain, it can cause you to feel like skin crawling, along with itchy eyes and runny nose. We're dismissing the root cause, taking into consideration exactly what the patient's telling you, and then prescribing polypharmacy medication based off of that. Often I would see patients on multiple medications that weren't necessary. For example, methamphetamine users oftentimes have underlying diagnoses that we're not looking into. They did not start using that drug for only the purpose of enjoyment. Oftentimes it was to mask an underlying mental health concern like attention deficit disorder, like schizophrenia, like bipolar, things that helped level them out on the street because they were not given the opportunity in office to get treated in the way that they should have. I wanted to piggyback off of your conversation about dental health. Substance abuse, high amounts of patients that do not go see dentists because of the disparity that they experience, and the fact that they are not given the opportunity to just be a patient. They are treated as if they are an addict. They are told, oh, you must have been an addict. Teeth are very important. And when you use substances, you degrade your oral health. And so having that, relationship between you and a provider where you feel comfortable going in and sitting down and not being judged for the choices that maybe you made in the past, and then being treated as a patient and being helped is part of that disparity as well. Patients need to feel like when they come into the office, again, they are not a burden, and that no matter what they came in with, that they are your patient and that they should be treated as such, no different than the person before them or after them. And I think often what I hear from the patients that I worked with in that setting, as well as the women that I work with, is I am not important to my healthcare system. And I think that's a big thing that needs to be conversated about is substance abuse is very active in this community. And the only way to get to the root concern is to actually take time to figure out the why. Part of that is child, trauma. Part of that is underlying mental health conditions, underlying other health conditions that maybe the person's not even aware of, like autoimmune conditions or cardiovascular conditions. We need to be more proactive in taking more initiative in the practitioner setting to ask more questions, less time jotting down the symptom list, and having more deep conversations about the connections between gut health. Gut to brain access is a very big thing right now, and we need to be going further in our healthcare system.
Thank you all again. As you were talking, I was thinking about how impactful it is to hear you say that, representing the organizations that you work for, that you are taking these efforts to hear patients and to make shifts, and encouraging our community members and patients to express themselves and to feel welcomed in the healthcare setting. And hopefully that will, as we have more of these conversations and as the work that you've done starts to impact our community more and grows, we'll see improvements. But I'm curious, a couple of you mentioned some efforts that you've put in place through training, through survey, through shifting your approach. How have you seen, what shifts and outcomes have you seen as a result of some of that work that you've done?
I'm proud to say just in the last couple of weeks, Marlene and I have had lots of things to celebrate in terms of seeing our work starting to come to fruition. Is, at least for us, we're starting to get referrals from other community partners, even though everyone that we serve is a regional center client. Our work with collaborating with community partners has made it so the care team is now calling us. We got a call from the social worker at St. Joe's ED saying there's a client that's been brought in. We really think they need your support. Reaching out, asking about training, coming to us saying we want to partner with you. So it's not just us going out there going, hey, we're here to help. It's now people starting to partner and take advantage of that. So we've had some celebratory moments the last couple of weeks going, it's working. Because like I said, we're a relatively new team. So it's a lot of boots on the ground trying to get that established. But really our goal is to make sure that we really are connecting. And being able to talk and listen to our community partners. Like we were sitting here talking about Ruiz, and I mentioned that there was this really great program that Ruiz brought to the regional center, and I saw clients benefiting from it, and then it went away. And where did it go? And I reached out to the provider and was like, can we do this again? We really need this medical advocacy class. And our clients were benefiting from it. And she's like, well, it was through Ruiz. Okay, so let's do this again. So knowing who to connect to and be able to share the information from one another really helps us highlight how we can connect and how we can partner. So a lot of it is really just telling each other what we're experiencing and sharing it like we're doing on this panel right now, which it increases those connections and allows us to be more successful in knowing what our community needs. And then all of us that are motivated and want to participate, which is everyone here, reaching and touching each other's, work and collaborating. So.
Well, there's lots to say, but I think one of the things that doesn't directly answer the question, but something that we hear again and again and again and again and again from providers who come to our community, whether they're temporary traveling providers that we call locums, or whether they are providers who moved here from a more urban area like LA, or whether they are residents, like advanced practice clinician residents who move here from another area but are staying like connected to fellow residents who are at the same level of training but in another organization in another region, is the patients here are the most complex patients I've ever seen. And we really have spent time digging into this with our providers of like, what do you mean? What do you mean they're the most complex patients you've ever seen? And there is a clinical acuity, but it's more than that. It is all the social drivers of health that are around a person and a human, in addition to having one of the highest rates of adverse childhood experiences in the country. And that what that shows up as for a provider who does have limited time, because they are trying to see as many patients as possible, and they do have the burden of all the clicks in the inbox because we are on electronic medical records, and there are obligations for documentation and getting referrals out and closing the note and getting the billing done so that, it can go out and we can get paid. It's so much larger than what a provider can take care of in the four walls of that exam room in a 20-minute visit. And so what additional support and layers can an organization like Open Door provide to those providers and to that care team and to that patient that can try to support them through that process, so that the provider isn't trying to address the psychosocial, the fact that they don't have transportation, the fact that they don't have housing, the fact that they are using substances, the fact that they haven't been to a dentist in 3 years, all within that medical visit, when they also have diabetes and hypertension and a skin condition, and they were just hospitalized. And so there's all of that slew of work, is building that community around that provider. And that's something that we really focus on at Open Door, is that it's not about the provider. Yes, the provider is very important, and the provider has certain qualifications and education and clinical acumen that no one else can have. But man, there is a lot that a care team can do. And so we have really expanded our case management program, which are our community work, our sort of community health workers, case managers, social work case managers, who can spend that time and spend an hour with a patient and really dig deep into what all their social needs are. And they remain linked and connected with other community members so that they have that awareness and knowledge. That's been a huge benefit of the CalAIM program in California, is that there's now a way to bill for that important work. And that is at risk with the financial challenges that the state's facing and with the changes happening at the federal level. So I saw in the last panel, there was a question that I think we didn't get to around like, what are going to be the consequences of the federal cuts at the federal level and the state level? Those are the types of programs that are going to be cut and are going to be hard to maintain without that funding. Additionally, medication-assisted treatment and having group visits and bringing patients together with shared experiences in that group setting with behavioral health support, that yes, a provider can do the prescribing of the Suboxone. That's a piece of it, but it's also that foundational counseling and that group setting and that peer sharing that is part of that healing process and part of that sustaining. And so those are the types of programs that we've also been implementing and seeing a lot of really wonderful success. And then another thing is behavioral health. One of the silver linings, happy learnings of COVID was that of all the types of care to provide virtually, behavioral health is one that works really well. We found when we had to pivot due to the social distancing and, obvious concerns of COVID, we could do a lot of medical care virtual. There's also a lot of medical care that shouldn't be done virtual. Whereas behavioral health, our no-show rates went down. Patients were more likely to follow through on a phone visit with a behavioral health clinician than they were maybe to get off work, drive in, wait, show up, be vulnerable. And so we've really been able to capitalize on that, and we've been able to expand our behavioral health clinician workforce and psychiatry to 40 providers over the last 4 years, because we've been able to go beyond having to have a full-time provider here all the time. We have a blend of in-person and virtual. And so that's another thing that's been a huge support. It used to be about 10 weeks. If your provider referred you to behavioral health, it took 10 weeks to get in. Now we're able to get someone in within 2 days. So that's huge when it comes to that, the importance of that medical and behavioral health combination in support of our patients. So those are some of the things. Oh, one other thing, since I was on the soapbox about our residents, a lot of our residents are from out of the area, and a lot of our residents are different ethnicities, and maybe English isn't the first language, and maybe they moved here from another country where they were a physician. They moved to the United States. They had to go back through medical school, and now they're in their residency. And I see, because I see all of our ethics points, our consolidated situation reports, a lot of times it's sort of that reverse where patients, they don't want to see that provider because they can't understand them, or they just don't feel a connection to them. And so creating a welcoming environment for providers who are from out of the area and who aren't from here and who don't understand rural communities. And again, that kind of like patience and partnership and creating a sense of belonging is another thing that I think we as a community can really push ourselves on.
So one thing that we do at Lima's Pharmacy is we create continuity of care between providers and patients, especially when referencing hormone replacement therapy and hormone consulting. So we do a lot of collaboration with providers who may not have the time to take with someone who has a complex issue like hormone replacement, or maybe the provider's not comfortable, speaking to that subject. So we're there to be a liaison to educate the community, educate the providers, but we also do seminars. Seminars that we hold in our house just to provide for the community members to learn about different aspects of hormone consulting, adrenal care, chronic fatigue, libido, things that are kind of taboo sometimes to speak about, but it's really important. It also builds a community of people. It builds a community of women and of men, because we do see men too. It creates this conversation that is very important to have in our healthcare system, where people are able to be very fluid in a non-biased environment that's very calming and kind of cute to be able to spend that time together and sit down and talk. So we do seminars. We also have a lot of patients that get referred to us by providers to just, go over things. We also are your specialized medication compounding pharmacy, and compounding is kind of a complex idea. It doesn't make sense to providers. They often have difficulty understanding what that means. What it is specialized medication that you cannot get, and I will repeat this, that you cannot get at the regular retail pharmacy. So If you can get it at a chain pharmacy, you likely cannot get it with us. However, say you're a patient that has a lactose allergy or a celiac disease. I will let you know, as a pharmacy student and future pharmacist in my last year, my TIAC, there is a lot of things in your medication that you're not aware of. You may take out gluten out of your diet. You may not know that there are gluten derivatives in your thyroid medication, in your medication. So the very thing that your doctor prescribes you to fix the problem that you are currently fixing in your own life with your food and your environmental toxins could also be in your medication. So we provide the special part of this. We also provide vet medications. As we know, those of us that love our animals, we will spend a lot of money on them. We will also do a lot of things for them. And it's important that we have access to care. So we compound medications for animals. We compound medications for your cat, because no one likes to give a cat a tablet. Don't try it. I highly do not recommend. We also specialize in special medications for your patients who have J-tubes, who are unable to swallow medication. We provide special suspensions. We also do a lot of the injectables for your hospital. So when you go in to get your eye doctor goes in to do surgery, a lot of times we're the ones that are compounding the injections that they use to numb your eye, to keep you from having any kind of infection in your eye. And we're a pivotal piece of that. And why we're a pivotal piece is because we're still community based. We want to stay that way. And I think that's the biggest conversation that we're having here today is, how do we keep things local? Well, Chewy.com does not do that for you. Your compounding pharmacy out of, LA does not do that for you. So, going to outside healthcare systems because you don't want to try to work with the companies locally because you're concerned about price, give us a call. Oftentimes we can make things work for you before you know it or are able to understand it. Healthcare systems like Open Door, they provide services at rates that you cannot compete with oftentimes. And it's important that we utilize these local places because, like she said, the residents that are coming in, do we want them to stay? Yes. We want to keep putting back into this community. One thing we're doing now is inviting food trucks to park into our parking lot, not because I necessarily should have all of that food, but it's nice on my lunch break, but also because it's community driven. It means that we're working with local companies to come in and park in our parking lot to provide food for the very sparse, area that we're in that district of healthcare where there's only 2 restaurants, which we love. I love my Ramones girls. Don't get me wrong. But I want to provide another opportunity for local providers, nursing staff, healthcare staff that works at Open Door to be able to walk down on their lunch break and be able to have food in an environment that they're supporting another local company that maybe wouldn't have, any kind of exposure on the other side of Eureka by a nursing staff. So we're doing a lot of different things. We also have a local food company that has come in, Clean Queen Meal Prep. So it's providing good, clean meals for people. We have high efficacy supplements that you cannot get from, other pharmacies. What we're trying to do is create a wellness center. We have an aesthetic company that's connected to us, an acupuncture and Chinese medicine that is within our complex. We think it's really important to create modalities for patients. We are not all the same. Every single person you see on this panel is different and unique in every single way. So part of what we do at Lima is advocation, education, and then continuity and opportunity. So that's something that's really important. I think that it's working well organically. And I also think that it's important to showcase that the local companies that you've seen in business for many, many years, when they're going out of business, it's not a light choice. It is a desperation. It is sadness. It is broken heart for them to close. Your local companies that have had to shut down, your local pharmacies, Rite Aid pharmacies are closing now. CVS pharmacies have shut down. You're seeing more and more pharmacies close, and it is due to, in part, insurance companies, which we don't play a role with, but it's also due in part to the fact that the staffing does not want to work in an environment that is not conducive. I will add to what we've talked about in respect to providers having some issues with racial concerns. Patients are not nice sometimes. I know that's kind of hard to understand, but sometimes you guys are really mean. We have to be kind to our healthcare providers. They may not do everything you want them to do, but I promise using foul language and screaming at us will never get the job done faster. So please, please, please give love and respect to your providers. They are only in this position because they care. Oftentimes, the pay is very low in respect to what they could get in another area. Oftentimes, the housing is different in this area. The patient demographic is hard. Be kind. I promise they will help you if you're kinder. And to add to that, if they are foreign, they still have the same education. Oftentimes, they are just as smart, if not smarter. Give them a chance. Just because their voice sounds different does not mean that they don't have the education to back them for what they're going to give you.
Thank you for shedding light on that experience for our community and those watching and joining us today. I'm really impressed by the comprehensive approach to healthcare that you're all sharing today, and I just want to take an opportunity to shift our conversation a little bit. And I think a couple of you kind of teed this up, but we want to examine, or just take a little bit of time to examine, the relationship between our rural setting. And so I feel very fortunate that we have you here, Dawn, and others to help interpret this data. We can obviously make some observations. So on the previous chart, we see a comparison between our Redwood Coast region and the state. And I'm hoping that we can just have a conversation about how our rural setting impacts the care that we get, and where we do see disparities, how are those exacerbated by our rural healthcare setting, and what access we have. And then in addition to this chart, we also have just a quick a bit of data here that reflects both premature death rates and life expectancy rates. And you can see just pretty easily here that Humboldt's premature death rate per 100,000 is significantly higher than the state's. And similarly, the life expectancy rate for the state being 81 years and Humboldt's at 77. You know, those are some really, for people that are not professionals, I think that that's a really easy way for a person to look at that and see we have some issues. And how does our rural status sort of impact or add to those outcomes?
Is it on now? Oh, I still haven't learned how to use the microphone. Okay, yeah, I could talk about this slide. And again, you did a great job of explaining what the meaning of this slide. And a lot of times we talk about this as length and quality of life. And so we all want to live long lives, and we want a quality of life. What is important about this slide is really looking at the difference between California and the Redwood region. And I will say this is not just true for the Redwood region, but if you go over to Shasta, Modoc, Trinity, Tehama, we've looked at the whole rural north, and those counties consistently rank in the lowest quartile of counties in the state of California. So there are complex reasons behind these. The county's public health department looks into this in depth in their community health assessment and health improvement plan, which I know you have cited as additional resources. And there are a lot of factors. We had some analysts really, really look into this, and health provider shortage. So not just for medical health, but oral health, behavioral health. We are absolutely a health provider shortage area. and the training and education. So if you want to become a hygienist, you can't do that here. You have to go out of the area to Santa Rosa or Reading. So those things we've already talked about. But the other things that really contribute to premature and early death have also been brought up, and they relate to behavioral health and substance abuse, and to some degree the geography. So like lots of 2-lane windy highways, which if you combine the driving roads like that with being under the influence, so it is a combination of factors, but it really does, these numbers really do a lot come down to substance use, to our high suicide rates, which are tied to behavioral health, and those really are the behaviors. Tobacco use, we've made lots of strides with tobacco use. It still continues to be a leading cause of death. So those kinds of things that we've talked about, they're not just impacting providers who have really complex patients. They're actually contributing to this disparity and other things too. But those are the things that we emerged in our research. And the good news about those factors is that they are preventable. They can be changed. People can recover. People can maintain sobriety. They are things that they are not our destiny. And so these are things that can be changed. And think about it. If some of those things shift at a community level, yes, we would still need more providers, but our existing providers could spend more time with more patients. Like there's a community benefit to all of us if we're healthier as a community. Who else wants to weigh in on this one?
So one of the things I just kind of wanted to shift a little bit, I feel like it falls under the umbrella, and then we've talked about like access and how travel is an issue, and that's all very true. But what we haven't discussed is really the idea of thriving. So I think one of the things that needs to shift in this county a little bit is just the whole paradigm of our medical and our behavioral health care being there for us to survive versus accessing care to thrive. So pretty much at this point, most people are going to access care when something's broken, right? Or when they're not feeling right. And that's limited if even access because of the trust issues and all the other things that happen. But if we're able to start taking a little bit of a shift and looking at our care being there to help people thrive, one of the big words that we use a lot at START is PERMA. And it's not really an adjective. It gets described like that. It gets used a lot of different ways. But PERMA is really that idea of well-being and thriving and what goes into that. And that it's about positive emotions, engagement, relationships, meaning, accomplishment. And that all of those things together really help make up a person who's thriving and our wellness. And it can't just be about what pill is right or what therapy do I need. It really is about what is creating meaning for that individual, what is helping them feel like they're accomplishing something. And I think that perspective really is kind of a little bit of a shift that we all need to start to bring into our perspective of how do we help people thrive, and that the access to care isn't just there to survive, that we need to be looking further, and that idea of PERMA is very proactive, right? Like really helping people understand and acknowledge what makes us tick, what motivates us, what helps us want to get out of bed, what makes us look at the world in a positive view, and really kind of counters a lot of that depression and substance abuse and a lot of the things that we see. tied in with the trauma and the rural living and the access to care. So just wanted to kind of bring that to light, because PERMA to me is a very important key for all of us. And I run around saying PERMA all the time, so it would be very amiss to not bring up PERMA.
And tell us what it means, because I had not heard of that.
I wrote it down. I like it. Well, I feel like I shouldn't say this because of everything that was so uplifting about PERMA and Thrive. And I will. So Open Door, we are the largest provider in the community of primary care. And I got some notes from our member services team before doing this panel on the most updated information of people calling them to get access to care. And they got 121 calls this month of community members who are calling them to say, I need a doctor. They've had almost 1,000 calls since January. And so at Open Door, one of our biggest, I mean, it's a really unfunny joke that we're called Open Door, and we say, like, we're kind of like half a jar door, because we do serve almost 60,000 community members. And the latest information that I've heard is that there's about 20,000 community members who don't have access to primary care, who don't have a primary care provider. And that is really, really devastating. And it's devastating, I take it personally as a place that wants to be able to really have an open door for anyone who needs access to care. And so one of the things we do look at is, what are all the ways that we can support and partner and do preventative care? We have our dental programs that go to the schools. We have our, we partner with the county to really support the tooth program to get that education out to our young children so that they understand the impact that they and their parents and their families can have on their oral health, so that we don't then see a patient, a young patient in the van who has to have 7 teeth extracted at age 6 due to dental decay, which is something we do see, and we don't see it infrequently. And so those types of, one thing, I grew up in Garberville, but I lived in the Bay Area for 11 years, and I started working in healthcare in the Bay Area before moving back. And one of the first things when I came back to Humboldt County and I was sitting in the room at the IPA with all these community groups was like, wow, Humboldt County collaborates. And it collaborates meaningfully. In the Bay Area, there's a lot of turf wars and sort of faux collaboration, but really competition. And in Humboldt County, we collaborate sort of out of necessity. We're scrappy, we're creative, we're innovative, and we really do partner. And that is really meaningful and is, I think, the reason, one of the real ingredients for the success and the longevity of this community, and why people do come and they stay despite some of the hardships of the region.
Just more me being positive, but it falls right in line with that. There is 21 START teams in the state of California, and the goal of every START team is to partner and build linkages within the network and the community. Recently, we heard from our national team that our START team here in Redwood Coast has had more success engaging law enforcement and our emergency room department and our providers in a collaborative effort than any other of the 21 teams in California. So.
So I don't have much to speak on this except really about women's health, because it's kind of a driver for our business. When we're looking at, life expectancy and, death rates, I want you to think of women when you think about that, especially your women of age. Oftentimes they are the women that have had cardiac events and did not know it, have had strokes, did not know it, have issues sleeping. Sleep is a big, huge part of our metabolic need in our body. There are countless women that do not sleep more than 5 hours a night. That is imperative that you get help and find the root cause of that. Often it is a hormone imbalance. Sometimes it's a neurological imbalance. Sometimes it's an adrenal issue. But those are concerns, and that contributes to the overall death rate when you're looking at women, especially when we're looking at cardiovascular health. Our number one killer is heart disease. Oftentimes, it is due to a lack of hormone balance. Hormones are not the all inclusive. There's much more to this. There's lifestyle. There's eating. Eating is a big, huge thing too. Making sure that you're getting adequate nutrition. So this all falls into our county, numbers, because we are a pretty health conscious community. However, we fall short in some of those spots that are, things that we should be doing, like sleep, like mental health, like substance abuse. Alcohol is a very, big part of our culture in this country. And oftentimes we don't talk about it being a part of the problem. We often use substance abuse as the drugs that are not legal in this country. However, alcoholism is a very big thing, and we do need to be open about that. It needs to be something that's conversated more about with cancer risk, because we do see a link in that. We see a link with autoimmune diseases and other cancers. So not having that preventative care over time and waiting for long periods of time before you get help is often, once you get there, you are a complex patient because you've had 20 years of a diagnosis that should have been helped and dealt with. So, kind of looking at your life expectancy is also about longevity and thriving, like you talked about. Thriving is important. You should not be surviving. That is one thing that I often tell my patients is you're running from a predator. That's what your brain is doing all the time. It's running from a predator. Ain't got time for a salad, you got time for a Snickers bar. So often there is this adrenal driven kind of body that you're just running on because you haven't dealt with the other underlying conditions that have been in your life for many, many years. And you finally hit a wall and decide to go to your provider. At that point, you become a complex patient, and it becomes very difficult to just give you one diagnosis because you have many things going on. So I challenge every patient and person that's watching this and in the audience to make sure you're getting your preventative care. And if you are a woman and you feel that you're not advocated for, to contact, me and Lima's Pharmacy, and we can be a liaison to support you and get studies out to you, and efficacious supplements to help you with the sleep, things with wellness, with emotional wellness. Those are all important aspects, and they lead to bigger problems when they're uncared for.
Thank you all. I almost hesitate to go to the next slide just, because of the positivity that's coming from this conversation, which I really value and appreciate. And I'm seeing that where we're lacking in number of providers and maybe specialists, we have a very strong sense of collaboration and community that's coming out. And I hear the message that you're all stating that we want to continue to enhance that, invite our community members to become even more of a part of this conversation on an ongoing basis. But I still should take us to the next slide. And I just want to talk briefly before we give our audience a chance to ask a question or two. The intersect between poverty and our Humboldt's healthcare outcomes. We have a little bit of data on how, again, comparing rural Humboldt County, rural Northern California to the rest of California, or California as a whole. And I'll use my little clicker here. So you can see here on this image that we grabbed some data, some state data that points to percentages of poverty. So for the state of California, the folks living in poverty are at 12%, whereas in Humboldt County, it's 20%. We have notable high housing costs in relation to income. We have a very high homeless population, and of the homeless, 79% are unsheltered. We have 60% of kids in our community that are leveraging free or reduced lunches. And obviously the poverty is impacting children significantly. And so I just wanted to look to you all to just maybe briefly talk about how you see poverty intersect with our healthcare outcomes in the work that you're doing.
Is it on? There we go. Why am I having so much trouble with the microphone? It's just a button, people. It's just a button you click. Poverty is absolutely one of the root causes. And we see this like disparities in poverty. Again, we see it in Humboldt, we see it in Del Norte, we see it across California's rural north. Again, that's another very busy chart. But when you look at those darker boxes, what you see is how poverty shows up and populations that are affected differently by poverty. We have gender up here on this one, as well as other factors like age, ethnicity, educational attainment, and work. And again, with this chart, if you're going to study it further, look at those darker boxes and see that, like, it is kind of interesting in Humboldt, our 18 to 34-year-olds, there's a 30% poverty rate. So how, what's going on there? Always ask yourself with these, like, what is going on with this data? We also, if it's not on the chart, but I actually remember from our studies that we also had in Humboldt and the region lower participation in employment for 18 to 34-year-olds. So this is called prime age employment. Like, this is the age where most people are, it's prime age for working. And we see lower rates of that population working, and probably complex reasons why. Some of that, as we started to dig, some of what we found actually were things like disability, higher rates of disability that contribute to your ability to participate in the workforce. There's a lot to unpack with that. With educational attainment, we know from lots of studies that, higher degrees of education is associated with higher socioeconomic status. We actually have better educational attainment rates in Humboldt than in some of the other counties that do not have a public four-year university. But these things really matter and impact poverty. So if you look at that bottom one, the unemployed to working full-time, look at how the shift in color goes in that bottom chart. So what you're seeing is, and of course, poverty and unemployment go together, right? That makes sense. But these are, it is definitely an issue. We look at poverty from like a variety of data sources. So there's census data that tells us about this. We always look at free and reduced price meal eligibility, another program that I believe is like maybe getting cut. I sure hope not. And then the other one is the percentage of the population that's eligible for Medi-Cal. And this is a big topic and a troubling topic to talk about because there are some changes, maybe some changes coming. And it is important to note it is going to disproportionately affect Humboldt and other rural counties that have at least 40% of the population. Like 4 in 10 people are on Medi-Cal. And so these are the kinds of data points we look at to understand poverty. There's a lot more, rising cost of food, of gas. So if you have to drive a long way, you have to spend a lot on gas. If your food costs more, if your housing costs more, all these things, the kind of environment that we're in now is concerning, especially for people who are already in poverty. And we may see more of that if we continue to see costs rise, wages and jobs not keep up. So I think this is a really important slide, and I'd love to hear if anyone else wants to speak to this one.
Yeah, Open Door has a mobile van, a mobile medical van in both Humboldt County and Del Norte. We've been able to begin our Del Norte van just this last year, and we've been really, really delighted by the enthusiastic response we've gotten from the community out there. There is a day in the week where we park the van in the parking lot outside of our brick and mortar health center, and we have people who will come to the van because they're more comfortable coming to the van and they don't want to have to sit in a waiting room, and they're able to kind of mingle outside or, you know, come and leave and come back. So the access that we've been able to reach just by shifting the way we're providing really the same care. And we have a doctor up there who is very, very passionate about specifically this care. He came to Open Door because he wanted to work on the van and because he wanted to increase access specifically for community members who don't have houses and who struggle in all of these areas. And so we see that on the real level every day, both in Humboldt and Del Norte County with our van. And the changes that are happening with the funding will absolutely impact those services and the patients we see on those services. If we're talking about work requirements and we're talking about having to demonstrate through paperwork, all that goes into not only having employment that counts towards the work requirements, but also demonstrating in the complexity if anyone's ever had to file for anything through the government. I've been pregnant, I've had a child, and I know how hard it is to coordinate with EDD, and that's probably one of the most common and frequent uses by people of our governmental support and funding systems. We're going to see major impact on the access to insurance, Medi-Cal in particular, and the access to healthcare for people who fall in this quadrant of all ages. And so I would be remiss if I didn't really underscore that point that you made, Dawn, since that is something that's being actively discussed by our legislators right now.
I'll be super quick because we just have a couple minutes. I just wanted to kind of tie this all together, and it just looking at, and I know we all know this, but the higher levels of poverty equal oftentimes lower level education, lower, like those entry level jobs, which means less flexible schedules, which means less ability to go out of the county, less ability to flex time to meet people's needs. It also means it's harder just to travel, just in general financially, but all of that adds to a feeling of often helplessness and increased depression that is felt by not just the person trying to access, but their system too. So we really are seeing much higher rates of depression and anxiety and feelings of helplessness in our lower income population, just based on just the struggle that comes with the economic situation.
Hello, testing. Thank you all. This is awesome. You all have provided a bunch of really good information. If I may, I want to sort of explore this concept of thriving that Wendy shared. But first, let me just say that sort of as an organization development practitioner, I completely agree with you with thriving, right? Like, our employees, if we can create a culture and an environment where our employees not only just want to come to work, check the boxes and leave, but they actually want to realize their potential in our workplace, then that helps us reach our organizational potential. And in public sector organizations, the ultimate benefit of that is to the taxpayer because we become more efficient and whatnot. But is it really realistic to go from where we are now to thriving? And if so, what's that look like?
I think it looks like empowerment and understanding, and everybody taking a minute to start to appreciate what we have, looking at what brings us enjoyment and sharing that with one another. And the power of positivity is infectious and it grows rapidly. So you really only need one player in the environment who continues to be that voice of positivity. Hi, zesty one over here on my my character my character strengths. That's infectious. And the more that is in any environment with any group of professionals within any family, it starts to carry from one to another. And it's like a snowball. And it may start really tiny with little snowflakes sticking together. But the more those snowflakes make a ball, the faster the ball starts to roll and the bigger it becomes. So yes, it's absolutely possible. And I really think it just takes some loud voices to have that frame of mind and to continue to bring that into the staff that they work with and those people that they touch with the work that they do, and kind of keeping that light and that positivity going and focusing on what brings people meaning and accomplishment. And it starts to really carry pretty quickly. I belong to a group called Proof Positive, and one of the things we do, it's the Autism Alliance Wellbeing. And one of the things we do is really research the effects of PERMA and that and how it grows. And what we see is that it doesn't take a big group of people to start to make a large impact. And that once you start to see the change, it's really infectious and it spreads. This isn't a good analogy, but it spreads like disease. It spreads really fast, right? I should think of a better analogy because that's kind of a yucky way of saying it. But that's really what happens. It's quick. So.
Thanks.
All right. Well, we are going to take our last minute or two to see if we have any questions from the audience. Yeah, I apologize. We are out of time, but I do want to just remind folks that a big part of the reason that we're here today doing this event is to share information, to educate our community, to invite our community in. We saw a lot, of the conversation that was shared about collaboration today and about all of us working together, regardless of our role in the community, to improve disparate outcomes, to improve access as a whole, to improve the experience that we have. And thank you all for being a very important part of that conversation.
Yeah, thank you. I've been itching to say this. And I think I speak for a lot of people who are watching this and who will watch the recording later. I was spellbounded by the conversation, and you took it off, and you had a great challenge ahead of you to unpack and discern, dissect a very complex issue, explaining disparate impacts within a geographic region, across geographies, within population segmentations, what it means to be able to support that type of complex patient, right, across disciplines through collaboration, how you covered proximate factors to health outcomes and determinants, like social determinants, and how it looks when all various systems of medical care interact with one another. And beyond that, right, other systems that are not necessarily medical adjacent, such as our police force, but why it's important to also connect with them. Anyway, there was so much information in there. I'm missing a whole bunch of other stuff. So I'm really thankful that we got to record this, and looking forward to have more iterations of these conversations so that we're eventually have time to be able to answer some of those questions. Thank you so much.
So thank you again to our panelists. The last thing that we will do today is our friends at Delarte have provided us with 2 tickets for the opening night performance on June 20th of keeping with the healthcare theme, Love is the Best Doctor. And we had seat C13, which I think, did you move? Were you down there and then you moved up? So congratulations, you were the winner. You can come on down, grab these tickets. Again, courtesy of Del Arte. Thank you very much. We do want to thank Del Arte for renting us this wonderful space. We want to thank our panelists. We want to thank our audience. We want to thank Greg. Shout out, Greg, for all of your help. Thank you very much. We are HR professionals. We are not healthcare practitioners in any way, shape, or form. But what we saw was that we felt like there was a lot to be added to this conversation regarding healthcare in Humboldt. So in other words, just looking at it through recruiting and retaining primary care physicians really left a lot on the table, and we saw like those gaps, and we really wanted to like fill them, and we thank you for helping us fill them today. Round of applause for our panelists. Thank you very much.